And her areas of interest are neonatal and pediatric anesthesia. And she'll be speaking on weaning criteria. Dr. Kanta, please.
Hello everyone, we'll be talking about weaning criteria. A patient requires mechanical ventilation when he is unable to support his ventilatory demands, which can be due to some disease process or due to inadequate ventilatory drive, which can again be due to some disease or some drug. Mechanical ventilation should be ideally discontinued and artificial airway should be removed as early as possible to avoid any ventilator-induced lung injury, any ventilator-associated pneumonia, airway trauma due to the artificial airway, or to avoid any need of unnecessary sedation or muscle relaxation. In up to 80% of the patients requiring temporary mechanical ventilation, especially less than a week, this process of discontinuation of mechanical ventilation is quite straightforward. But in certain patients, especially the ones who require prolonged ventilation, this process may be quite complex and lengthy. So this gradual reduction of ventilatory support from the patients who are improving is called as weaning. And an estimated of 40% of duration of mechanical ventilation in the patients who have been on prolonged ventilation is dedicated to this process. There are certain factors that must be taken into consideration in case of weaning, that your patient may still require ventilatory support during weaning, that is step down ventilation, or he may still require some amount of supplemental oxygen or PEEP to support oxygenation. Some patient may require artificial airway even after discontinuation of ventilation. For example, patients with some lesions in the tracheobronchial tree, patients with the facial burns, etc. There are certain parameters which are intended to help the clinicians predict the success of the weaning attempts. For example, heart rate variability, the quality of sleep. The poor sleep is associated with weaning failure. Similarly, a weaker hand grip denotes a prolonged weaning. Diaphragmatic dysfunction, which can be seen by the use of ultrasound by measuring the diaphragm thickness at the end of inspiration and expiration, and seeing the difference of greater than 30% predicts extubation failure with a sensitivity of 88% and specificity of 77%. Similarly, higher level of oxidative stress markers are associated with prolonged weaning. The task force of American College of Chest Physicians, ARC, and Society of Critical Care Medicine in 2016 gave evidence-based guidelines for the patient who required ventilation for greater than 24 hours. And they came up with 3 key points which have evolved as the criteria for weaning. Number 1, the problem that has caused the patient to require mechanical ventilation must have been reversed before you think about weaning. Secondly, certain measurable criteria should be assessed to help establish a patient's readiness to establish discontinuation of ventilation. And thirdly, a spontaneous breathing trial should be performed to firmly establish the readiness of weaning. Moving on to the first recommendation, that is to take care of the pathology of ventilator dependence. Though this is a first recommendation, but it is often overlooked. You have to search for the causes for which the patient is dependent on the ventilator, and this is especially important in the patients where the previous attempts to wean have failed. You have to look for the clinical factors which aids in evaluation of the patient's overall condition. The pathology which led to the patient on ventilator needs to be taken care of. Apart from that, the associated factors like if there is any acid-base imbalance, if there is any fluid imbalance, electrolyte imbalance, if patient is having any cardiac arrhythmias or the hemoglobin is low, there is calorie depletion which is leading to the respiratory muscle weakness, is there any infection or pain, all these conditions needs to be taken care of, apart from the thing that the patient should be conscious, oriented, alert. So state of consciousness is important, and the patient's psychological condition is such that he is awake, is responding to verbal command, and is completely oriented. Once we have taken care of the pathology which has led to the ventilator dependence, and we have taken care of the other associated factors, we move on to the assessment of readiness using the evaluation criteria. So, weaning criteria are that when the medical condition of the patient is stable, the patient is breathing spontaneously, is alert, cooperative. Clinicians typically evaluate certain ventilatory mechanics and gas exchange values to help assess the readiness for weaning. These values are known as weaning criteria, and 75% of the patients who meet these criteria, they tolerate a spontaneous breath test. But no single measure uniformly is successful in predicting weaning success. So what are the physiological parameters which are required for the weaning and extubations? First of all, we need to test patient for his ventilatory performance and muscle strength. So the vital capacity should be greater than 15 ml per kg body weight. Minute ventilation should be less than 10 to 15 liter per minute. Respiratory rate should be less than 35 breaths per minute, and the spontaneous tidal volume should be greater than 4 to 6 ml per kg body weight. The rapid shallow breathing index, which is the ratio of frequency to spontaneous tidal volume, should be less than 60 to 105 breaths per minute per liter. The reading is taken after 1 minute of disconnecting the patient or a spontaneously breathing patient from ventilator or oxygen. The patient's ventilatory pattern should be synchronous and stable, and the maximum inspiratory pressure should be less than minus 20 to 30 centimeter of water. The arterial CO2 should be less than 50 millimeters of mercury, that is, the gas exchange should be optimal. Then we move on to the measurement of drive to breathe. The higher the patient is having the drive to breathe, the longer is the weaning. That means the patient is having an air hunger. So the higher the drive, there are lower chances of patient getting weaned early. You have to check for airway occlusion pressure. A value greater than 6 centimeter of water reflects both higher drive to breathe and ventilatory muscle strength. The normal range being 0 to minus 2 centimeter of water. Once we have seen the ventilatory muscle strength and drive to breathe, we look for the patient's work of breathing. A patient on prolonged ventilatory support is sometimes associated with respiratory muscle weakness, which can be due to either disuse of those muscles because the respiration is being provided by the ventilator, or there can be an associated poor nutrition if that has not been taken care of. So this leads to increased work of breathing and ventilatory muscle fatigue the moment patient starts breathing spontaneously, and this is an important reason for the ventilatory dependence. So what are the signs and symptoms in measurement of increased work of breathing? If a spontaneously breathing patient uses accessory muscles of respiration, there is an asynchrony in the breathing, there is nasal flaring, diaphoresis, anxiety, tachypnea, substernal or intercostal retraction, patient's breathing asynchronous with the ventilator. Along with the level of work of breathing should be less than 0.8 joules per liter. It is a difficult parameter to measure. So is the oxygen cost of breathing, which should be less than 15% of the total VO2. Again, a difficult parameter to measure, that the total oxygen consumption should be less than 15% for the respiration out of the total oxygen consumption of the body per minute. The dynamic compliance should be greater than 25 ml per centimeter of water, and the ratio of dead space to tidal volume should be less than 0.6. Crop index provides a good assessment of potential respiratory muscle fatigue and overload. It evaluates the dynamic compliance, respiratory rate, oxygenation, and inspiratory pressure. This is the formula for the crop index, where the value of greater than 13 indicates the likelihood of successful weaning. Now that we have taken care of the primary pathology, we have taken care of the ventilatory mechanics of the patient, the muscle strength, the drive to breathe, the work of breathing. When all these things have been taken care of, we move to the measurement of adequacy of oxygenation. The oxygenation should be adequate for the patient to breathe spontaneously for prolonged duration of time, to breathe on his own and to maintain it for the longer duration. So this patient needs to initiate his or her own respiratory effort, should have an adequate hemoglobin for its oxygen carrying capacity, should have stable hemodynamics with a heart rate of less than 135 per minute, with no clinically important hypotension, with low or no inotropic support. The arterial oxygen should be greater than 60 millimeters of mercury on an FiO2 of 40%, and oxygen sats to be greater than 90%, with a PEEP of less than equal to 5 to 8 centimeters of water. The PaO to FiO2 ratio should be greater than 150 to 200 millimeters of mercury, and the ratio of arterial to alveolar oxygen should be greater than 0.47. The percentage shunt fraction should be less than 20 to 30%. There should not be much wasted oxygenation and ventilation. The pH of the patient should be 7.2. There should not be any respiratory or metabolic acidosis, because such patient won't be able to sustain the breathing, spontaneous breathing, for a long time. So once we have seen all these mechanics and oxygenation of the patient, we move on to assessing this patient for the spontaneous respiration. We can put the patient either on pressure support or a minimal amount of ventilatory support, or you can give a TP's trial to these patients. So this is the best approach to determine a patient's readiness to wean. A spontaneous breathing test is typically conducted when the basic findings, which we've already discussed, are shows that the patient is ready to be weaned, but the clinicians nonetheless is uncertain about the patient's ability to sustain the breathing without the mechanical support. It has a screening phase. You let the patient breathe spontaneously for a few minutes and see whether he'll be able to sustain this for a longer duration of time. Once you are sure of that, then the patient is allowed to breathe spontaneously for an extended period of around 30 to 120 minutes. That's called spontaneous breathing test, at least 30 to 120 minutes. And while the patient is undergoing an SBT, you have to observe the patient for hemodynamic stability, respiration, adequacy of gas exchange, and subjective comfort. So SBT has already been established as a key index of the patient's ability to be weaned from the mechanical ventilation and for successful extubation. So according to studies, they say that up to 75 to 85% of the patients with successful SBT can be successfully weaned and extubated without requiring reintubation. But a close monitoring is a must for SBT, so that you do not unnecessarily prolong the SBT, as it may cause muscle fatigue, hemodynamic instability, worsening of the gas exchange, and the patient's discomfort. It may rather prolong your weaning than being helpful. So what are the warning signs that indicate the problems during an SBT? Any increase in respiratory rate greater than 30 to 35 breaths per minute. So the clinician should watch for any increases of more than 10 breaths per minute or decreasing below 8 breaths per minute of the patient. The tidal volume decreasing below 250 to 300 ml. The blood pressure changes significantly, as demonstrated by a drop of 20 millimeters of systolic or a rise of 30 millimeters of systolic blood pressure with systolic values greater than 180 millimeters of mercury, or a change of 10 millimeters of mercury of diastolic blood pressure. Any increase in the heart rate by greater than 20% from the baseline, or the total heart rate of more than 140 beats per minute, along with the plus any sudden onset of frequent VPCs, diaphoresis, is alarming. Clinical signs and symptoms that indicate deterioration of patient's condition, or that demonstrate that the patient is anxious, not ready for weaning, and must be returned to ventilatory support. This has to be supported with the changes in the ABG and oxygen saturation. Once we've had a successful SBT in the first trial, we can think of removing the artificial airway. But the patient needs to be assessed for the airway patency or his ability to protect his or her airway, because the common risk factors which are associated with extubation are airway obstruction, aspiration, and inability to clear the secretions. Therefore, a strong cuff reflex and a peritubular leak should be there for a successful extubation. So Successful SBT after first attempt can be we can think in terms of extubating the patient, removing the patient from the mechanical ventilation. But failed SBT at first attempt or SBT which has required up to 3 attempts but has required less than 7 days to reach the successful SBT, there the weaning is known to be difficult. Whereas in the similar situation where to reach a successful SBT it has required more than 7 days, the weaning is said to be prolonged. So in difficult and prolonged weaning, you can have a graded decrease in the mechanical support for the successful weaning of the patient. So there you can go for the weaning modes, though it is out of the context of these lectures, like intermittent ventilation, or you can go for the pressure support ventilation. In intermittent ventilation, the patient and the ventilator share the weight of the breathing initially, which is gradually transferred to the patient, supported by the investigations like ABG and hemodynamic stability. Similarly, in pressure support ventilation, you give a predetermined amount of pressure support during the inspiratory breath till the airflow declines and the patient exhales. So this pressure support can gradually be decreased over a period of time, bringing it to a level where the patient is breathing spontaneously with hardly any support required from the machine. But whatever the situation in all the patients who are having prolonged ventilation where the SBT is unsuccessful, even where you are going for the step down ventilation, the patient still needs to fulfill all the weaning criteria before the decision to take off the ventilator is made. So this emphasizes the importance of weaning criteria in all the patients who have been in mechanical support, especially for a prolonged duration of time, and who has required a graded liberation from the mechanical ventilation. So I hope I was able to explain the weaning criteria properly to you. I hope you'll be at least be able to write a small short note, which is usually the question in the exams in the MD or the DNB. All the very best for your exam. Thank you.
Thank you, Dr. Kanta. I should congratulate both the speakers. Dr. Abhishek, you really presented it, compiled it very well and presented very nicely. And Dr. Kanta also concised the topic and presented well. So now the house is open to questions.
There are no questions from the delegates, ma'am. Anything that you wish to add from your end?
I think it's the time because otherwise such a topic and no questions is really, you don't expect that. And I think
the last day and the last lecture, so maybe everybody is exhausted.
So even if I also say something, I don't think people will be very much interested in listening, but still I would like to add few things. First thing is, first I will take the non-invasive ventilation. As Dr. Abhishek showed, it is very important whether you are using single limb circuit or double limb circuit, because if you use single limb circuit and there is no venting, it is very detrimental. And it has been shown again and again, so you should take that point, one thing. And another thing is you should know when not to prolong non-invasive ventilation and when to go for invasive ventilation. It is very important. And non-invasive is good, all of us know. And as an anesthesiologist, we should, target and use non-invasive ventilation as a therapy. Like we use invasive ventilation, we know how much rate we are setting, how much tidal volume we are setting. Similarly, we should, it's like ek jana gaya 10-5 ka lagaya, dusra gaya chal 8-6 kar diya. It is not like that. We have to target it. It's the same patient, like invasive patient, non-invasive also. We should be, we should know whether the patient requires oxygenation or ventilation. When patient requires oxygenation, it is the PEEP which needs to be titrated. When patient needs ventilation, it's the driving pressure. That is the difference between inspiratory and expiratory pressure. Similarly, during weaning also, we have to do it in a graded fashion. ये नहीं जब मर्जी ठीक लग रहा है patient निकाल के बाहर कर दिया. So suppose we have to, we are seeing that patients' oxygenation parameters are improving. Then we have to decrease step by step our PEEP. Like that is lower pressure, and the upper pressure can be decreased to the similar fashion so that driving pressure is the same. Similarly, if hypercapnia is there, then we have to, like if oxygenation is less, then we have to increase the PEEP, then we have to increase the upper level also, so that CO2 retention will not occur. I hope I'm clear what I'm telling. Yeah. And similarly, during weaning, we have to decrease rate so the timings are increased and the patient is breathing in between. So that is there, and there's so many things to be said, but one more thing is the CO2 is as important as oxygenation. Like patient retains CO2, patient will have like increased pH and acidosis, that will be equally detrimental, in fact more, because oxygen will, everybody focuses on oxygenation, it will be detected. Increased CO2 will not be detected that easily. And as far as weaning criteria are concerned, another important thing is when we start weaning. All of us want to wean the patient as soon as possible from the ventilator, but we have to see, is it the right time to wean the patient? Because if we do it at the wrong time, we'll just keep calculating weaning criteria daily and it will not be of any use. And then clinically, we have to be, we have to judge the patient clinically. And we say that patient is on CPAP pressure support. But if pressure support is very high, it acts as an independent ventilatory mode. So your patient is practically on a controlled ventilation. So you have to see what levels my patient is on. Then you have to think of a gradual weaning. And then your weaning criteria fit in once you think that patient is doing well on that. And as far as indices are concerned, none of them is, first of all, nothing is, replacement of a clinical judgment. And then if you use them in combination, like most of them are a good guide. And we have to follow them daily. And then few things have been shown to be more useful, like rapid shallow breathing index, especially in combination with P 0.1. And inspiratory pressures are important. And this crop index, they have been shown useful in the literature. That's it. So
thank you, ma'am.
Children must have been benefited with very good presentations by both the speakers.
I would also like to again thank and congratulate the APPEC team for I mean, this program has been really successful, running for a few years now, and very successful they're running it. So I would like to really congratulate the entire APPEC team for this, and also thank you for making me part of this program.
Thank you so much, sir. Thank you for your contribution, and thank you for being a part of APPEC2023.
And one more thing is that diaphragmatic thickness fraction is also coming up in a long way with good specificity, predictivity, as well as sensitivity.
Thank you, ma'am. Thank you so much. And thanks to both the speakers for such a wonderful presentation. And thank you for being a part of APPEC2023 once again.
Thank you.
Thank you, everybody. This is the...
And thank you, RML and team.
So finally, we have come to the end of this 7-day program. Thank you, Dr. Abhishek. Thank you, Dr. Anshu, and thank you, Dr. Meena. It's a pleasure to have such a good faculty, because eventually it's the faculty and the participants who make the course. On behalf of RML Hospital, on behalf of full faculty of RML Hospital, Team APPEC, I profusely thank everybody. All the faculty, chairpersons, speakers, and the participants. Would like to, some of the faculty is here with us as of now. Dr. M.D. Kaur couldn't be here because of some reason because of which she can't join us. She also joins, all of us on our behalf, thanking him. Dr. Klesh, part of our core team, Dr. Namita Saraswat, also part of our core team, who have worked behind the curtain for making this program I would say it's a success, because when it completes so properly and like everything can be done so smoothly. On my own, I would like to say I'm like really happy and privileged to be part of it. And Dr. Nitin, who has been working relentlessly for last 7 days to make this program smooth and on time, and coordinating with all speakers and chairpersons and everybody. Thank you so much. We have our team of 2 postgraduates also with us, Dr. Neha and Dr. Shreyash, who have been our backbone as far as the technical aspect is concerned. And I would like our Dr. Akhilesh to say something to address everybody.
It was nice to meet everyone, and see, learning is always a bilateral experience. So we learn while teaching. So it's good, and we learned a lot, and hope we could impart few things to the postgraduates. Thank you.
Dr. Namita, please say something to everybody. You have been working behind the scenes for such a long time.
Yeah, first of all, ma'am, I would like to thank, it has been a great opportunity for me also. I would like to thank HOD ma'am, Neja ma'am, you and Akhilesh sir also for giving and having faith in me. And I'm sure all the students might have benefited a lot from this program. It is a comprehensive program, and I would like to wish them all the best for the exam. Thank you.
Thank you, Dr. Namita. Dr. Achal, I could see you here. Are you there? But if you have lost if you're not there on video call for whatever reason, it would be really good if you can also give your input. Could you speak a few words?
Good evening, ma'am. Am I audible?
Yes, you're audible. Please,
yes.
Dr. Achal.
Ma'am, a big congratulations to everyone in the department. I think it's a departmental and institutional success. And these academic activities, they are good for us. They are good for students. And I wish all the best to all of them. And I request them to give us a true, genuine feedback so that we can improve next year.
Yes. I agree with this wholeheartedly, because unless we get genuine feedback, we can't improve. Like the feedback, the first time we got it, that it was like really long. So we decreased it from 9 to 7. So in case if there are some topics that you would like that they were too much, so everything that made a program.
हमने PDF भेजा है,
any kind of
वो सब इनको दे देंगे ये लोग,
Every-
नोट्स बना लेंगे उससे. हमने तो 5 जगह से पढ़ के जैसे मैंने बनाया, उनके पास अब कंपाइल्ड है. जो मेरा टॉपिक था ना, वो यूजुअली पढ़ते नहीं है बच्चे, उनको समझ नहीं आता, तो उनको एक जगह पे सब कुछ मिल जाएगा.
So, and we would be, and in the end, I would like to say, besides this feedback, you would also be getting written information in the form of PDF format of all the lectures. And please feel free to contact the core team with whom you have been in touch. Yes, Gurmeet's thing would be out, but otherwise you will be in touch with each other. Anybody else? Dr. Nitin, you would like to add something?
Thank you, ma'am. Thank you to MD ma'am and to all the people who have been there and who have supported and who have given us this opportunity. I hope the students have immensely benefited from this course, and we look forward to having an even better program in coming years. So feedback is very essential for us. Please, I've been requesting this from the past 6 days, and today's the last day. So again, I would urge all of you to please give your genuine feedbacks, because we really want to make it one of the best running PG assembly, so that you can immensely benefit in the coming years. And that's all I would say, and all the best to all the postgrad students. Thank you.
Thank you, Dr. Nitin. And on behalf of ma'am, Dr. MD Kaur, I would like to say we'll meet again next year. Will we meet again?
Thank you.
Bye.
Just a request to the postgrad students and the delegates, kindly, the quiz has got activated. This is the last time that you have an opportunity to get your registration fee back. Please do attempt the quiz, and you will be informed. Whoever is the winner will be called telephonically and will be informed, so don't worry about it. And do fill in the feedback forms. We are really looking forward to genuine feedback from all of you. Thank you so much. And thank you for being part of APPEC by being a delegate to it. Thank you. We look forward to many more registrations in coming years. Thank you.
Yeah, big thanks to the delegates. Thank you so much.
And lastly, thanks to our IT team, Minutes and more. Thank you so much for your cooperation.
Yes.
Thank you.
Yes, it was very, very smooth. Thank you.
Thank you, sir.